Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. David Dingli, who's an MD, PhD, professor of medicine at the reputed Mayo Clinic in Rochester, Minnesota, which is one of the preeminent institutions in the world for plasma cell dyscrasias, myeloma, amyloid, and then POEM syndrome, which we're going to talk about today, which is a more rare entity. Welcome, David.
Thank you, Dr. Vich, for inviting me.
Thank you for being here. So, for our audience, can you tell them what the acronym POEM syndrome really means?
Yes. So, as you mentioned, POEMS is an acronym, and it relates to the presence of polyneuropathy, organomegaly, endocrinopathy, a monoclonal plasma cell disorder, and skin changes. And we can probably expand a little bit on what these are. So, polyneuropathy, this means damage and symptoms related to nerves. And these are peripheral nerves. So typically, the problems start with a sensation of numbness or stabbing pain in the feet that can progress to involve the arms, and if untreated, will move upward, move more proximally in the body. Initially, it's a sensory problem with these symptoms that I mentioned. And sometimes people will have a sensation of coldness in their feet, even though they have a good circulation. In time, if undiagnosed and untreated, it will start involving muscles. And it will start involving muscles of the feet and legs and move upwards. And the pattern is actually quite important. If it's a hereditary neuropathy or a drug-induced neuropathy or, say, B12 deficiency, symptoms often would start in the feet, and progression tends to be quite slow, and oftentimes muscle weakness does not occur. In this condition, the tempo of progression tends to be a little bit faster, and muscle weakness tends to follow soon after the onset of sensory symptoms. So it will be unusual to have a POEM syndrome who has had sensory symptoms for 5 years, and then we diagnose it. Typically, things occur a little bit at a faster clip. And it is important to diagnose it because of this issue that symptoms can get worse quite rapidly, and the patient can be in a very difficult situation quite fast. We can talk about the pathology of the neuropathy maybe a little bit later, but let me go through the rest of the acronym. So organomegaly means enlargement of organs. And in POEM syndrome, we think of 3 organs that can be affected, or organ systems. Either the liver gets enlarged, or the spleen gets enlarged, or lymph nodes get enlarged. And sometimes this is something to be clinically appreciated when you examine the patient. The liver edge is palpable, or the spleen is palpable, or there may be lymph nodes in the neck, or in the armpits, or in the groin. Oftentimes, the organomegaly is much more visible on imaging. When we do either CT imaging or PET-CT, more relevant for this type of disease, and we can find organ enlargement. The endocrinopathy means diseases of hormone-producing glands, and there are various that can occur. And starting with the most common, this typically affects the gonads. So men will have low testosterone levels. Females may have problems with fertility. The prolactin levels may be elevated. And this will manifest itself in various ways: fatigue, maybe change in skin color, anemia, infertility. It can cause erectile dysfunction in men, change in body hair. The next will be thyroid diseases, in particular hypothyroidism. Some people may develop diabetes mellitus in relation to this. The adrenal glands can be affected with low cortisol levels. And very infrequently, you will find involvement of the pituitary gland with growth hormone abnormalities. But if you suspect a patient has POEM syndrome, in our protocols, we will test for all endocrine systems in each patient. The monoclonal plasma cell disorder is a critical component for the diagnosis of POEMS syndrome. And plasma cells are cells that live in the bone marrow and normally produce immunoglobulins. Now, in POEMS syndrome, at least the more common variant, there will be a population of these cells that are abnormal, and they produce the same protein that we can detect in the blood. And there are some characteristics of this protein that are quite relevant and can provide hints to this diagnosis. So maybe some members of the audience would know that immunoglobulins come in two variants, kappa or lambda light chain restricted. In POEMS syndrome, almost always, the monoclonal protein is lambda. Whereas in myeloma, 2/3 or more are kappa light chain restricted. In POEMS, almost all patients will have a lambda light chain restricted population of plasma cells and a small lambda light chain restricted immunoglobulin in the blood. And one needs to be very cognizant and look specifically for this monoclonal protein because it can be very small. You're not going to find a protein of 3 grams per deciliter. Most times it will be less than a gram. And sometimes it's only detectable by immunofixation, which is a very sensitive test to look for this monoclonal protein. The same would be with light chains, immunoglobulin light chains. They tend to be present, but not very high concentrations. And then skin changes are also very common in POEMS syndrome, and they can be very variable. You can have the patient who has hyperpigmentation, so the skin looks darker, or they have increased body hair, or they can have, they can have red papules that show the so-called cherry angiomas, often on the trunk, or the patient may have some gynecomastia, so a male will develop some sort of breast tissue. There can be changes in the nails. The nails can become clubbed, which is a peculiar change which the patient will be able to figure out. The nails can become quite pale. And some people will also develop a purplish discoloration of their hands and their feet, which will not be due to congestion. It's just there. So it's something, again, very particular, and if one is tuned to it, one can find it. Now, these are the main characteristics. We will come to some more characteristics defined by another acronym called PEST, which we will come to. So POEMS is actually a fairly rare disease, and there have not been many epidemiologic studies to look at its incidence. There was a study in Japan, and they could determine that incidence there was 0.3 patients per 100,000 population. So effectively, you need about 1/3 of a million population, and you can find one patient. Mm. So it is a relatively rare disease. But the rarity of it does not excuse us from diagnosing it, because therapy, as we will discuss in a bit, can be very important and life-saving for patients with this disease. Many patients are in their 50s, but patients have been diagnosed as early as in their 30s and as late as in their 80s. And generally, males are affected a bit more often than women. So approximately 60-65% would be males compared to around 35 to 40% females.
So how do you diagnose it? Obviously, the POEMS is an acronym, and you don't have to have all of those characteristics. And there are some characteristics that are not even covered in the POEMS acronym and are required now for consideration of diagnosis. So how do you know that you're dealing with a POEMS patient?
Yes, so there's a class system that actually helps us diagnose this condition with very high reliability. And as the audience can see here, there are mandatory major criteria. One of them is the polyneuropathy, usually demyelinating, but it can also be axonal or mixed in some patients. The second is the presence of a monoclonal plasma cell proliferative disorder. So the patient who has a polyneuropathy, especially fairly rapidly moving polyneuropathy, and a serum monoclonal protein or clonal plasma cells should be one thing that we need to be thinking about, especially if the monoclonal protein is lambda light chain restricted. Now, most of these patients will have an IgA or an IgG monoclonal protein. And IgM will be very infrequent, probably around 2% or less of patients. But again, whereas in multiple myeloma, probably 50 to 60% would be IgG, and about 30% would be IgA. In POEMS, things are a little bit different. The majority of patients will have an IgG lambda monoclonal protein. So we need the two major criteria. Then there are the mandatory major criteria. Then we have other major criteria, and we need at least one of them. And those will be either Castleman's disease or sclerotic bone lesions, elevation in VEGF. So let's start with the sclerotic bone lesions. So most people would know that in myeloma, we have this lytic bone disease in about 70 to 80% of patients. In POEMS syndrome, there can be bone disease, but typically it is sclerotic. So instead of having destruction of bone, there is new bone formation. And this could be localized, as in one vertebra, or in the pelvis, for example, or in a rib, or it can be diffuse. And this actually has implications for how we treat the patient. VEGF levels are a very important part of the consideration for the diagnosis, and they can be very important to look at response to therapy, as I'm sure we will talk in a little bit. Castleman's disease is a rare condition where there is often enlargement of lymph nodes in one part of the body, so-called unicentric Castleman's disease, or diffuse lymphadenopathy, with a very particular histologic appearance. And the diagnosis of Castleman's disease requires a very astute pathologist to make the right diagnosis. And Castleman's disease can be associated with HIV in some individuals. In other patients, it is not associated with HIV and may be associated with other viruses. So we need one of these three criteria. In my practice, most patients will have sclerotic bone disease. Maybe 20% would have Castleman's disease. And most patients, not to say all of them, would have elevation in vascular endothelial growth factor. And then there are the minor criteria. As you can see, there are about 6 of them, and we need at least one of these to make a diagnosis. So we already talked about the organomegaly, enlargement of the spleen, liver, or lymph nodes. Something we have not discussed yet is the second acronym, which is PEST. And PEST stands for papilledema, so that's point number 10, which is swelling of the nerve that takes signals from the eye to the brain. And this is something that we can detect clinically or an ophthalmologist can confirm. It's not very common in POEMS syndrome, but I certainly have seen it in at least several of my patients as a manifestation of the disease. So papilledema, E is extravascular volume overload. So some of these patients may have edema, or they can have fluid around their lungs or fluid in their abdomen in the absence of heart disease, liver, or kidney disease. That, again, that should be a clue that there could be POEMS syndrome with a vascular leak component. S stands for the skin changes that I kind of mentioned already, the hyperpigmentation, increased body hair, hemangiomas, the plethora that I mentioned, this redness in the extremities, white nails. And some patients may have an elevation in their platelets or red blood cells. And it is important to note that in this situation, the expansion of the platelets and red cells is not clonal. So in these patients, you will test for the JAK2 and MPL and calreticulin, and they will be normal. But it is actually important because these patients are at some risk of blood clots because reactive erythrocytosis or thrombocytosis. I've already mentioned the clubbing and potential weight loss. Some patients may have restrictive lung disease or a problem with diffusing capacity in the lung and pulmonary hypertension. And this can be quite an important problem. In fact, whenever we suspect a patient having POEMS syndrome, regardless of whether they have pulmonary symptoms or not, we will do pulmonary function tests and an echocardiogram. So to wrap up this slide about diagnosis, to make a diagnosis, we need the mandatory major criteria. We want one of the major criteria, so sclerotic bone disease, and often we'll have two of them. In fact, I don't think I remember a patient who had sclerotic bone disease and POEMS and did not have an elevated VEGF. And then we need one of the minor criteria.
So a couple of questions that I had. One is that do you do nerve conduction studies, nerve biopsies for determining the kind of neuropathy for all your patients?
So when we have a patient where we suspect POEMS, invariably we will do an EMG, and invariably we will enlist the input from our peripheral nerve specialists and we will let them decide whether a nerve biopsy is needed. Sometimes when the story is not ironclad, then a nerve biopsy may be needed. But oftentimes with the clinical picture and the EMG findings of a mixed pattern, often of demyelination, but also with axonal features, that will be, in the right context, will be quite suggestive of POEMS syndrome.
The second question I have is a lot of texts and articles talk about elevated protein in the CSF. Do you do lumbar punctures?
Generally, not. The only time we will do a lumbar puncture if, for example, there is a concern that this could be CIDP. In CIDP, then yes, I think our neurology colleagues will do a spinal tap. But in the right context, I do not see the value of a spinal tap myself. I don't think it's going to help me make the diagnosis, especially in the presence of all the other supporting evidence that would guide me to this diagnosis.
So how do we treat this disease?
So I will address this in two ways. First, there is therapy directed at what is driving the disease process. And then there is the supportive care that goes towards making sure the patient is well. And those can occur concurrently. So to address the underlying process. So the underlying process is going to be either sclerotic multiple myeloma, or it's going to be the Castleman's disease. Most patients, it will be the osteosclerotic bone disease. And a point that I want to make, the clonal plasma cells need not be present in high numbers. In fact, it's possible that you can have a situation where a random bone marrow biopsy will not show any clonal plasma cells. But then if you biopsy an area of sclerotic bone disease that typically is identified by PET imaging, then you'll find the clonal plasma cells. Now, some patients would have a single sclerotic bone lesion, or 2 or 3 lesions close to each other. In that situation, one can try to eradicate the clonal plasma cells by radiation, assuming this can be given safely without damage to surrounding organs. And some of these patients can do very well with radiation alone. If the patient has disease in multiple sites, so a random bone marrow biopsy shows clonal plasma cells, and the PET CT shows multiple lesions in various parts of the bones, then obviously radiation therapy is not the way to go. In that situation, there are various ways in which we can treat the patient with systemic therapy. Some of these patients can be excellent candidates for upfront autologous stem cell transplant. And we've had excellent experience with this approach if the patient is fit to undergo the transplant. But the transplant needs to be done in an expedited fashion, because sometimes the disease is evolving rapidly, and it's not rare that the patient goes to transplant and will require inpatient rehab after, because they continue to lose some ground in the interim. So if the disease is quite active, I would probably not proceed with transplant immediately, but I will try to control the disease, buy time, stabilize the patient, and then go to transplant.
So what are the chemotherapeutic drugs broadly that you consider for these patients?
So the drugs that we generally like to use would be either IMiDs, so lenalidomide with dexamethasone, for example. We've used proteasome inhibitors with dexamethasone, and now we can use even CD38 antibodies with, for example, a proteasome inhibitor and dexamethasone. So carfilzomib, daratumumab dex, for example, or daratumumab dex can be used in this context. Or, as I mentioned, autologous stem cell transplantation can be used. And these patients then, as I mentioned, require a lot of supportive care. And the supportive care needs to take into consideration any endocrinopathies that are present, fluid status, symptoms related to neuropathy, pulmonary status, and of course, the risk of infections. In fact, in the bad old days, patients used to die because of bronchopneumonia. And there is some element of immunosuppression related to the disease, immunosuppression related to the treatment. So aggressive antibiotic prophylaxis, vaccinations, and proper care for and prompt attention to infections is quite important.
You mentioned proteasome inhibitors, but you didn't mention bortezomib, I presume, because of the neuropathy associated with the drug.
Yes, in this situation, I would prefer to use carfilzomib because of the significantly lower risk of inducing or worsening neuropathy. Yes.
And for the patients who are eligible for transplant, whether it can be done quickly or whether you need to do some cycles of chemotherapy before transplant, is transplant your goal? Or is that something that even in a transplant eligible patient, you choose who to take to transplant and who not to?
So my approach is that if a patient can go to transplant, I like to get them there, because the transplant provides them with an opportunity to be off treatment. And we know that patients who achieve a deep response with transplant can do very well in the long term. In fact, I've had patients who did not need any subsequent therapy for many years, and they improved, and the quality of life improvement was significant after we were able to get over the acute episode. So if the patient can get to transplant, I like to get them to transplant. If the patient's medical situation is such that transplant is prohibitive, then I will treat them in this approach that I mentioned. And of course, these approaches do not preclude a transplant in the future, in principle. And this is one reason why, for example, we do not like to irradiate too much, because if we irradiate many areas of the bone marrow, we could potentially compromise stem cell collection in the future. But for the patient with a very localized plasmacytoma, localized radiation is a very effective therapy, or potentially is a very effective therapy.
So what is the prognosis of these patients? A lot of times when patients have neuropathy, especially if they start getting muscle weakness, people are very discouraged. Have you seen a neuropathy improve? Have you seen patients, overcome a lot of the acute manifestations that they present with at the beginning?
So the short answer is yes. I mean, we've had patients who we initially saw who were in a wheelchair because of the neuropathy and weakness. And with appropriate therapy, they were able to return to normal walking. The endocrinopathies improved. The fluid retention issues that they had resolved, the cytosis that they had would resolve. So there is actually a lot of hope that in these patients, symptoms can get considerably better. Certainly, the muscle weakness that they have improves. The numbness, and does it always go away? I think that's tough. But certainly the patients appropriately treated will be much better off in the long term.
And so you said if for localized, you could just radiate. So have you seen even radiation lead to just resolution of systemic symptoms?
Yes, we have had patients where just local radiation to a plasmacytoma, if we were convinced it was the only site of disease, and typically this would require that we have a PET scan, which shows only one side of disease. We have a bone marrow that is negative, but then biopsy of the site that is hot on PET showing that there are the clonal plasma cells. Yes, that can actually result in a resolution of symptoms in quite a number of patients.
That's remarkable that even one site of disease can cause so much havoc, and then just simply radiating a small area sometimes can lead to resolution of symptoms.
Yes, because the syndrome is a paraneoplastic phenomenon. So the severity of it does not correlate directly with how much plasma cell burden exists. It's more by how active they are and what sort of cytokines they are producing, and control of that site that is producing these cytokines presumably is able to control the disease in the long term. And as you know, plasma cells are very sensitive to radiation, and that is the rationale behind the local radiation therapy in these patients.
Well, I really want to thank you for taking the time to so elegantly explain POEM syndrome, its manifestations, its treatment, and I'm privileged to have you on this talk here today. And I hope I can turn to you in the future for other topics as well.
It's my pleasure. Thank you, Dr. Vij, for inviting me.
Thank you.